Question 1. Quality control measures reveal a case where a patient sustained a significant head injury in a motor vehicle collision. Post-resuscitation, the patient's Glasgow Coma Scale (GCS) score dropped from 14 to 9 within 2 hours, and a new ipsilateral pupillary dilation was noted. Considering the Advanced Trauma Life Support (ATLS) guidelines, which of the following actions is the most appropriate next step to address the potential indications for neurosurgical intervention? Option A. Continue serial neurological assessments every hour and administer intravenous mannitol. Option B. Focus on stabilizing the patient's airway and breathing, deferring further neurological assessment. Option C. Initiate immediate neurosurgical consultation and arrange for urgent head imaging. Option D. Administer prophylactic anticonvulsant medication and monitor for seizure activity. Correct answer is C. Initiate immediate neurosurgical consultation and arrange for urgent head imaging. Explanation. Scenario analysis. This scenario presents a common challenge in trauma care where a patient exhibits neurological deficits following head injury. Differentiating between reversible swelling and a surgically correctable lesion requires rapid, accurate assessment and understanding of ATLS principles. The challenge lies in the dynamic nature of head injuries and the potential for rapid deterioration, necessitating timely and appropriate intervention to prevent irreversible neurological damage. The ATLS framework provides a structured approach to guide these critical decisions. Correct approach analysis. Prompt neurosurgical consultation and consideration of imaging are indicated when there is evidence of a rapidly deteriorating neurological status or focal neurological deficits following head trauma, as these can signify a surgically amenable lesion such as an epidural or subdural hematoma. The ATLS guidelines emphasize the importance of identifying and managing conditions that can be rapidly reversed, and a declining Glasgow Coma Scale (GCS) score or the presence of pupillary abnormalities are critical indicators for such intervention. This approach aligns with the ATLS primary and secondary survey objectives, aiming to identify and treat life-threatening conditions promptly. Incorrect approaches analysis. Delaying neurosurgical consultation despite a significant drop in GCS score or the development of new focal neurological deficits is a failure to adhere to the ATLS principle of rapid assessment and intervention for potentially reversible causes of neurological compromise. This delay can lead to increased intracranial pressure and secondary brain injury, which are preventable. Administering empiric medications without a clear indication or definitive diagnosis, or solely relying on serial neurological examinations without considering advanced imaging when indicated by ATLS criteria, represents a deviation from best practice and can mask or exacerbate the underlying pathology. Professional reasoning. Professionals should approach such situations by rigorously applying the ATLS algorithm. This involves a systematic primary survey to identify immediate life threats, followed by a secondary survey that includes a detailed neurological assessment. When neurological deficits are present or worsening, especially with a declining GCS, the decision-making process should immediately pivot to considering neurosurgical intervention. This involves prompt consultation with neurosurgery and appropriate diagnostic imaging e.g., CT scan, to identify the specific cause of the deficit. The decision to intervene surgically is based on the presence of a surgically correctable lesion and the potential for neurological recovery. Question 2. The control framework reveals that a 45-year-old male is brought to the emergency department following a high-speed motor vehicle collision. He is obtunded, with a palpable radial pulse but no palpable carotid pulse. His chest is visibly moving with respiration, but breath sounds are diminished on the left. What is the most appropriate initial management step according to ATLS principles? Option A. Perform a rapid sequence intubation followed by a full secondary survey. Option B. Secure the airway with an endotracheal tube and provide ventilatory support. Option C. Immediately initiate a detailed neurological examination to assess Glasgow Coma Scale. Option D. Administer intravenous fluids to improve pulse quality and then assess breath sounds. The correct answer is B. Secure the airway with an endotracheal tube and provide ventilatory support. Explanation. The control framework reveals that the Advanced Trauma Life Support (ATLS) certification as a standard of care in emergency medicine mandates a systematic and prioritized approach to trauma assessment and initial management. This scenario is professionally challenging due to the potential for rapid deterioration of a critically injured patient, where a failure to adhere to established protocols can have life-threatening consequences. The urgency and complexity of multiple injuries necessitate a structured, evidence-based methodology to ensure all life-threatening conditions are identified and addressed promptly. The correct approach represents best professional practice because it aligns directly with the ATLS principles of primary and secondary surveys. The primary survey, airway, breathing, circulation, disability, exposure/environment, is designed to identify and manage immediate life threats. This systematic progression ensures that the most critical issues are addressed first, preventing a focus on less urgent problems, while a patient is actively dying from an airway obstruction or severe hemorrhage. Adherence to ATLS guidelines is considered the benchmark for competent trauma care in many jurisdictions, and deviations can be viewed as a failure to meet the expected standard of care, potentially leading to adverse patient outcomes and professional accountability. An incorrect approach that prioritizes a detailed neurological assessment before ensuring adequate airway and breathing is professionally unacceptable. This failure represents a direct contravention of the ATLS primary survey's mnemonic. Ethically, it demonstrates a disregard for the immediate life-saving priorities, potentially leading to preventable death or severe disability. Such an approach would be considered negligent, as it deviates from established, evidence-based protocols designed to optimize patient survival. Another incorrect approach, such as delaying definitive hemorrhage control to complete a full secondary survey, is also professionally unacceptable. While the secondary survey is crucial for identifying other injuries, ATLS explicitly states that ongoing, severe hemorrhage is a life-threatening condition that must be managed concurrently with or immediately after the primary survey. Failing to address massive bleeding promptly violates the principle of managing immediate threats to life and would be a significant deviation from best practice, with potentially fatal consequences. A third incorrect approach, such as administering pain medication before assessing circulation and identifying potential hypovolemic shock, is also professionally unacceptable. Opioids can cause vasodilation and respiratory depression, exacerbating an undiagnosed or untreated shock state. This demonstrates a lack of understanding of the physiological impact of interventions in the context of trauma and a failure to prioritize life-sustaining interventions over symptom management. The professional decision-making process for similar situations should always begin with a rapid, systematic primary survey, focusing on identifying and managing immediate life threats. This involves a structured assessment of airway, breathing, circulation, disability, and exposure. Once the primary survey is complete and immediate life threats are managed, a thorough secondary survey can be performed. Throughout this process, continuous reassessment is critical, as a patient's condition can change rapidly. Professionals must be proficient in ATLS principles and apply them diligently, recognizing that adherence to these protocols is not merely a guideline, but a critical component of providing safe and effective trauma care. Question 3. Market research demonstrates that trauma teams often face challenges in consistently and accurately assessing the neurological status of patients presenting with potential head injuries. Considering the Advanced Trauma Life Support ATLS certification requirements, which of the following approaches to assessing neurological status in a trauma patient is most aligned with best professional practice and ATLS guidelines? Option A. Forming a brief neurological check only if the patient appears to have obvious signs of severe head trauma, such as visible scalp lacerations or skull deformities. Option B. Utilizing the Glasgow Coma Scale, GCS, to systematically evaluate eye-opening, verbal response, and motor response, and documenting the score for serial assessment. Option C. Prioritizing the assessment of airway and breathing over a detailed neurological evaluation, assuming that neurological status will improve once circulation is restored. Option D. Relying on a general impression of the patient's responsiveness, such as seems awake or looks drowsy, without using a standardized scoring system. The correct answer is B. Utilizing the Glasgow Coma Scale, GCS, to systematically evaluate eye-opening, verbal response, and motor response, and documenting the score for serial assessment. Explanation. This scenario is professionally challenging because accurately assessing neurological status in a trauma patient is critical for guiding immediate management and predicting outcomes, yet it can be confounded by factors like shock, hypothermia, or intoxication. The ATLS framework emphasizes a systematic approach to ensure no critical findings are missed. The correct approach represents best professional practice because it aligns directly with the ATLS principles for disability assessment, specifically the AVPU scale, alert, verbal, pain, unresponsive, or the Glasgow Coma Scale, GCS, which are standardized, reproducible, and widely accepted methods for evaluating neurological function in trauma. These scales provide a baseline and allow for serial assessment to detect deterioration or improvement, which is crucial for timely intervention and communication among the trauma team. Adherence to these established protocols ensures consistent and effective patient care, minimizing the risk of misdiagnosis or delayed treatment, and is a cornerstone of evidence-based trauma management as taught in ATLS. An incorrect approach that relies solely on subjective impressions without a standardized scale fails to meet the rigor required by ATLS. This can lead to inconsistent documentation and communication, making it difficult to track changes in neurological status over time. Ethically, this represents a failure to provide the highest standard of care, as it introduces a significant risk of error. Another incorrect approach that prioritizes other assessments over a thorough neurological evaluation in a patient with potential head injury is a direct violation of the ATLS primary survey's systematic approach, where D for disability is a distinct and essential component. This failure to systematically assess neurological function can lead to overlooking critical signs of intracranial pressure or brain injury, with potentially devastating consequences. The professional decision-making process for similar situations should involve a strict adherence to the ATLS primary survey sequence. Upon initial assessment, the D component for disability must be addressed using a validated scale like AVPU or GCS. This assessment should be performed early and repeated frequently, especially if there are any changes in the patient's condition or if interventions are administered. The results should be clearly documented and communicated to the rest of the trauma team. If the patient's neurological status is unclear due to confounding factors, it is imperative to attempt to mitigate those factors, e.g., correct shock, to obtain the most accurate neurological assessment possible, rather than abandoning the assessment altogether. Question 4. The risk matrix shows that a delay in obtaining a complete ample history can significantly increase the risk of adverse patient outcomes. A paramedic arrives at the scene of a motor vehicle collision and finds a conscious but disoriented patient with visible facial trauma. The patient is able to respond to simple questions, but appears to be in significant pain. The paramedic needs to rapidly transport the patient to the nearest trauma center. What is the most appropriate approach to gathering the ample history in this scenario? Option A. Ask the patient direct, concise questions about allergies, medications, past medical history, last meal, and events leading up to the injury while simultaneously preparing for transport. Option B. Ask the patient only about their allergies and current medications, as these are the most critical components of the ample history in an acute trauma setting. Option C. Focus on the mechanism of injury and transport the patient immediately, deferring the ample history entirely to the receiving hospital. Option D. Attempt to obtain a detailed, narrative ample history from the patient, even if it significantly delays transport. The correct answer is C. Focus on the mechanism of injury and transport the patient immediately, deferring the ample history entirely to the receiving hospital. Explanation. The risk matrix shows that a delay in obtaining a complete ample history can significantly increase the risk of adverse patient outcomes due to missed critical information. This scenario is professionally challenging because the pre-hospital provider is under pressure to rapidly transport the patient while simultaneously gathering essential data. The ATLS framework emphasizes a systematic approach to trauma care, and a thorough ample history is a cornerstone of this, providing vital clues for diagnosis and management. The correct approach represents best professional practice because it prioritizes obtaining the ample history in a structured, efficient manner, even amidst the urgency of transport. This aligns with ATLS guidelines that advocate for gathering as much relevant information as possible without compromising immediate life-saving interventions. Specifically, asking the patient or accompanying persons about allergies, medications, past medical history, last meal, and events leading up to the injury provides a comprehensive overview that guides subsequent medical decisions, from diagnostic imaging to surgical planning. This thoroughness is ethically mandated to ensure patient safety and optimal care. An incorrect approach that focuses solely on the immediate mechanism of injury without probing for ample details fails to recognize the potential for coexisting conditions or contributing factors that could complicate the patient's presentation. This represents a regulatory and ethical failure by not adhering to the comprehensive assessment principles of ATLS, potentially leading to a delayed or incorrect diagnosis and treatment plan. Another incorrect approach that delegates the entire ample history to the receiving hospital without attempting any pre-hospital data collection is also professionally unacceptable. This bypasses a crucial opportunity to provide valuable information to the trauma team upon arrival, potentially delaying their assessment and intervention. Ethically, it represents a failure to act in the patient's best interest by not maximizing available resources for information gathering. Professionals should employ a decision-making framework that integrates the urgency of the situation with the necessity of comprehensive assessment. This involves prioritizing immediate life threats while concurrently initiating the ample history gathering process. If the patient is conscious and able to communicate, direct questioning is paramount. If not, information should be sought from family, friends, or emergency medical personnel who were present at the scene. The goal is to obtain as much ample information as possible without significantly delaying transport or compromising essential interventions. Question 5. Risk assessment procedures indicate a patient has sustained a severe, life-threatening hemorrhage from a deep laceration to the upper thigh. The bleeding is pulsatile and arterial. Which of the following actions best reflects the immediate management priorities according to the Advanced Trauma Life Support ATLS framework for controlling this type of hemorrhage? Option A. Apply direct pressure to the wound for at least 10 minutes, and if bleeding persists, consider a hemostatic dressing. Option B. Apply a tourniquet distale to the wound to minimize potential nerve damage, and then apply direct pressure. Option C. Administer intravenous fluids and blood products to improve the patient's hemodynamic status before attempting definitive hemorrhage control. Option D. Apply a commercially manufactured tourniquet proximal to the wound, tightening it until arterial bleeding ceases, and document the time of application. The correct answer is D. Apply a commercially manufactured tourniquet proximal to the wound, tightening it until arterial bleeding ceases, and document the time of application. Explanation. This scenario presents a professional challenge due to the critical nature of severe hemorrhage and the immediate need for effective intervention. The ATLS framework emphasizes rapid assessment and management of life-threatening conditions. The judicious use of tourniquets and hemostatic agents is a key component of managing extremity hemorrhage, but their application requires specific knowledge and adherence to established protocols to maximize efficacy and minimize potential harm. The ATLS provider must balance the urgency of bleeding control with the potential complications of these interventions. The correct approach represents best professional practice because it aligns directly with ATLS principles for hemorrhage control. Applying a tourniquet proximal to the bleeding site, ensuring it is tight enough to occlude arterial flow, and documenting its application are all critical steps. Similarly, the appropriate use of hemostatic agents, when indicated and applied correctly, can significantly aid in controlling bleeding that cannot be managed by direct pressure or tourniquet alone. This approach prioritizes patient safety and effective resuscitation, adhering to the evidence-based guidelines within the ATLS framework. An incorrect approach involving the delayed application of a tourniquet until after other less effective measures have been attempted is a significant regulatory and ethical failure. ATLS mandates immediate control of life-threatening hemorrhage. Delaying definitive control measures like a tourniquet when indicated can lead to irreversible shock and death, violating the ethical duty to provide timely and appropriate care. Another incorrect approach, such as applying a tourniquet distale to the wound or not tightening it sufficiently, demonstrates a lack of understanding of the mechanism of action and can result in continued bleeding and potential limb ischemia. Failing to meet the standard of care expected of an ATLS provider. The failure to document the application of a tourniquet or hemostatic agent is also a professional lapse, hindering effective communication and continuity of care among the trauma team. Professional decision-making in similar situations should follow a structured approach. First, rapidly identify and assess the severity of hemorrhage. Second, determine the most appropriate method for hemorrhage control based on the location and nature of the bleeding, prioritizing interventions that are most likely to be effective and safe. Third, implement the chosen intervention promptly and correctly, adhering to ATLS guidelines. Fourth, Continuously reassess the patient's response to the intervention and be prepared to escalate or modify treatment as needed. Finally, ensure thorough documentation of all interventions and patient status. Question 6. Assessment of a 45-year-old male involved in a motor vehicle collision reveals multiple abrasions, a suspected femur fracture, and significant external bleeding. The patient is conscious but appears diaphoretic and is shivering. The ambient temperature in the emergency department resuscitation bay is cool. What is the most appropriate initial approach to environmental control for this patient? Option A. Administer intravenous fluids and pain medication, then address clothing removal and warming. Option B. Focus on controlling external bleeding and stabilizing the fracture, with environmental control being a secondary consideration. Option C. Cover the patient with dry blankets while continuing to manage bleeding and defer clothing removal until after initial resuscitation. Option D. Remove all wet clothing, cover the patient with dry blankets, and ensure the resuscitation bay is warmed. The correct answer is D. Remove all wet clothing, cover the patient with dry blankets, and ensure the resuscitation bay is warmed. Explanation. Scenario analysis. This scenario presents a common challenge in trauma care, managing a patient with potential hypothermia while simultaneously addressing life-threatening injuries. The professional challenge lies in balancing the immediate need for resuscitation and intervention with the risk of further heat loss, which can exacerbate coagulopathy and worsen outcomes. Careful judgment is required to prioritize interventions and environmental control measures effectively. Correct approach analysis. The correct approach prioritizes preventing further heat loss and initiating active rewarming, while continuing essential trauma management. ATLS guidelines emphasize that exposure and environmental control are critical components of the initial assessment and management of the trauma patient. Removing wet clothing, covering the patient with warm blankets, and using external warming devices, if available and appropriate, are crucial to prevent hypothermia. Maintaining a warm environment in the resuscitation bay is also paramount. This aligns with ATLS principles of addressing reversible causes of death, where hypothermia is a significant contributor. Incorrect approaches analysis. Allowing the patient to remain in wet clothing without active rewarming directly contradicts ATLS principles by exacerbating heat loss and increasing the risk of hypothermia. This failure to address environmental control is a significant lapse in care. Focusing solely on active rewarming without addressing the underlying injuries or removing the source of heat loss, wet clothing, is incomplete and potentially delays critical interventions. It fails to integrate environmental control with other essential trauma management steps. Delaying the removal of wet clothing until after initial resuscitation is complete is a critical error. Hypothermia can develop rapidly, and delaying this simple yet effective measure can have severe consequences, including impaired clotting and increased metabolic demands. This demonstrates a failure to recognize the immediate impact of environmental factors on patient stability. Professional reasoning. Professionals should approach this situation by integrating the ATLS survey with environmental control. After initial assessment and airway management, the priority is to remove wet clothing, cover the patient, and initiate warming measures concurrently with addressing other life threats. Continuous reassessment of the patient's temperature and hemodynamic status is vital. The decision-making process should involve a systematic approach, recognizing that hypothermia is a treatable condition that significantly impacts trauma outcomes. Question 7. Comparative studies suggest that in a critically injured patient presenting with hypotension, tachycardia, and altered mental status, where the patient is unable to provide informed consent due to their condition, a physician's immediate ethical and clinical obligation is to: Option A. Initiate aggressive fluid resuscitation and blood product transfusion, while simultaneously attempting to contact the patient's next of kin for consent regarding further interventions. Option B. Administer broad-spectrum antibiotics and pain medication to stabilize the patient before further assessment of shock type. Option C. Focus solely on diagnostic imaging to definitively identify the cause of hypotension before initiating any therapeutic measures. Option D. Delay all medical interventions until the patient regains capacity or a legal guardian can be appointed to provide informed consent. The correct answer is A. Initiate aggressive fluid resuscitation and blood product transfusion while simultaneously attempting to contact the patient's next of kin for consent regarding further interventions. Explanation. This scenario presents a common ethical dilemma in emergency medicine, specifically within the ATLS framework, where a physician must balance immediate life-saving interventions with resource allocation and patient autonomy, even when the patient's capacity to consent is compromised. The challenge lies in recognizing and classifying shock rapidly and accurately to initiate appropriate treatment, while also navigating the ethical imperative to involve family or legal guardians when a patient is unable to provide informed consent due to their critical condition. The correct approach represents best professional practice by prioritizing the immediate, life-sustaining management of hypovolemic shock, which is the most life-threatening condition in this context. ATLS guidelines emphasize the ATLS approach, where immediate resuscitation takes precedence. The ethical justification for proceeding with fluid resuscitation without explicit consent from the incapacitated patient stems from the principle of beneficence and the doctrine of implied consent in emergency situations where delay would cause significant harm or death. This aligns with the ATLS principle of acting in the patient's best interest when they are unable to act for themselves. An incorrect approach would be to delay essential resuscitation efforts while waiting for family or legal counsel to arrive. This failure constitutes a breach of the duty of care and violates the ethical principle of non-maleficence, as the delay directly contributes to the patient's deteriorating condition and potential death. Furthermore, it disregards the ATLS mandate for rapid assessment and intervention in shock. Another incorrect approach would be to administer treatments that are not immediately indicated for the suspected shock type, such as broad-spectrum antibiotics without evidence of infection, or to focus solely on diagnostic imaging before initiating resuscitation. These actions would divert critical time and resources from life-saving measures and are not supported by ATLS protocols for initial shock management. Professional decision-making in such situations requires a rapid, systematic assessment using the ATLS principles. The physician must first identify the signs and symptoms of shock, classify its likely type, e.g., hypovolemic, cardiogenic, obstructive, distributive, and then initiate immediate, evidence-based interventions. Simultaneously, efforts should be made to contact family or legal guardians to inform them of the situation and obtain consent for ongoing care, but this should not impede life-saving measures. The decision-making process is guided by the principle of acting in the patient's best interest, prioritizing immediate survival, and adhering to established trauma care protocols. Question 8. Risk assessment procedures indicate a patient presence with multiple injuries following a motor vehicle collision, including a visible deformity of the left leg and signs of respiratory distress with shallow breathing and paradoxical chest movement. Which of the following represents the absolute priority of care according to ATLS principles? Option A. Initiating immediate imaging of the chest and abdomen. Option B. Stabilizing the fractured left leg to prevent further injury. Option C. Administering intravenous fluids to address potential hypovolemia. Option D. Securing the airway and ensuring adequate ventilation. The correct answer is D. Securing the airway and ensuring adequate ventilation. Explanation. This scenario presents a professionally challenging situation due to the inherent ambiguity and potential for rapid deterioration in a trauma patient. The challenge lies in accurately assessing multiple critical injuries simultaneously and determining the most immediate life-threatening condition requiring intervention, adhering strictly to ATLS principles. Careful judgment is required to avoid premature focus on less critical issues while overlooking a rapidly evolving, life-threatening problem. The correct approach represents best professional practice because it aligns directly with the ATLS philosophy of prioritizing interventions based on the ATLS approach: airway, breathing, circulation, disability, exposure. This systematic stepwise evaluation ensures that immediate threats to life are addressed first. Specifically, focusing on airway patency and adequate breathing is paramount, as failure in these areas leads to rapid irreversible brain damage and death. Circulation assessment, including hemorrhage control, is the next critical step. This systematic prioritization is ethically mandated by the principle of beneficence, ensuring the patient receives the most effective and timely care to preserve life and minimize harm. It also adheres to professional standards of care, which dictate that healthcare providers must act within their scope of practice and follow established protocols for trauma management. An incorrect approach that focuses solely on a visible but non-life-threatening injury, such as a limb fracture, before assessing airway or breathing represents a significant regulatory and ethical failure. This deviates from established trauma protocols, potentially leading to delayed or missed interventions for more critical issues, violating the duty of care and the principle of non-maleficence. Similarly, prioritizing diagnostic imaging over immediate resuscitation efforts for suspected internal bleeding would be an ethical and regulatory failure. While diagnostics are important, they must not supersede the immediate need to stabilize the patient and control life-threatening hemorrhage, as dictated by ATLS guidelines. This failure could be seen as a breach of professional competence and adherence to accepted medical practice. The professional decision-making process for similar situations should involve a rapid, systematic assessment following the ATLS mnemonic. This involves continuous reassessment and a willingness to shift focus as the patient's condition evolves. Providers must maintain situational awareness, recognizing that initial findings may not represent the most critical threat. They should rely on their training and established protocols, consulting with senior colleagues or specialists when uncertainty arises, always prioritizing interventions that address immediate threats to life and limb. Question 9. To address the challenge of a rapidly deteriorating trauma patient presenting with absent breath sounds on one side, tracheal deviation and hypotension, which of the following actions best reflects the ATLS protocol for identifying and managing life-threatening injuries during the primary survey? Option A. Immediately perform needle decompression of the chest. Option B. Proceed with a thorough secondary survey, palpating all extremities for fractures. Option C. Administer intravenous fluids and reassess vital signs before any other intervention. Option D. Obtain a detailed medical history from the patient or bystanders. Correct answer is A. Immediately perform needle decompression of the chest. Explanation. This scenario is professionally challenging due to the rapid deterioration of a patient's condition in a pre-hospital setting, requiring immediate and accurate identification of life-threatening injuries under pressure. The ATLS framework emphasizes a systematic approach to trauma assessment, prioritizing interventions based on the airway, breathing, circulation, disability, exposure. Failure to adhere to this systematic approach can lead to overlooking critical injuries, resulting in delayed or inappropriate treatment and potentially adverse patient outcomes. The correct approach represents best professional practice by strictly adhering to the ATLS principles for primary survey. This involves a rapid, head-to-toe assessment focused on identifying and managing immediate threats to life. Specifically, recognizing signs of tension pneumothorax, e.g., unilateral absent breath sounds, tracheal deviation, hypotension, distended neck veins, and initiating immediate needle decompression is a cornerstone of ATLS management for a life-threatening chest injury. This aligns with the ATLS guideline to manage life-threatening conditions as they are identified during the primary survey, before proceeding to secondary survey or definitive care. An incorrect approach of proceeding directly to a detailed history or a more thorough secondary survey without addressing the suspected tension pneumothorax would be a significant regulatory and ethical failure. This bypasses the ATLS mandate to prioritize life-saving interventions during the primary survey. Ethically, it represents a deviation from the standard of care expected in trauma management, potentially leading to preventable harm or death. Regulatory frameworks for emergency medical services and trauma care universally mandate adherence to established protocols like ATLS to ensure patient safety and quality of care. Another incorrect approach of focusing solely on a visible limb injury while ignoring signs of respiratory distress and circulatory compromise would also be a failure. This demonstrates a lack of systematic assessment, a core tenet of ATLS, and prioritizes a less immediately life-threatening issue over a potentially fatal one. This violates the principle of treat first what kills first, inherent in the ATLS methodology. The professional decision-making process for similar situations should involve a constant mental checklist of the Upon encountering a trauma patient, the rescuer must immediately assess for airway patency, adequate breathing, and signs of shock or hemorrhage. If any of these are compromised, immediate intervention is required. The presence of specific signs and symptoms, such as those suggestive of tension pneumothorax, should trigger immediate, life-saving procedures as outlined in ATLS, even if other injuries are apparent. The primary survey is a dynamic process. Findings at any step can necessitate immediate intervention before moving to the next. Question 10. Cost-benefit analysis shows that early activation of massive transfusion protocols MTP, in trauma patients with suspected massive hemorrhage significantly improves survival rates and reduces overall patient morbidity, despite the inherent costs associated with blood products and their administration. Considering the Advanced Trauma Life Support (ATLS) framework and its emphasis on timely intervention, which of the following approaches best reflects the professional and ethical imperative for managing a patient presenting with signs of severe hemorrhagic shock? Option A. Withhold MTP activation if the patient's condition is critical, prioritizing the conservation of blood products due to cost concerns. Option B. Delay MTP activation until laboratory results definitively confirm coagulopathy, even if the patient remains hemodynamically unstable and shows signs of ongoing severe bleeding. Option C. Initiate MTP based on clinical indicators of massive hemorrhage, such as persistent hypotension despite adequate fluid resuscitation and evidence of coagulopathy, without waiting for laboratory confirmation of coagulopathy. Option D. Activate MTP solely based on the volume of crystalloid infused, irrespective of the patient's hemodynamic status or ongoing bleeding. The correct answer is C. Initiate MTP based on clinical indicators of massive hemorrhage, such as persistent hypotension despite adequate fluid resuscitation and evidence of coagulopathy, without waiting for laboratory confirmation of coagulopathy. Explanation: this scenario is professionally challenging due to the critical nature of massive transfusion protocols, MTP, in saving lives during severe hemorrhage, balanced against the potential risks and resource implications. The ATLS framework emphasizes rapid assessment and intervention, and MTPs are a cornerstone of managing life-threatening bleeding. The decision to initiate or withhold MTPs requires immediate, expert judgment based on clinical signs and the potential for rapid deterioration. The correct approach represents best professional practice because it aligns with the ATLS principles of early recognition of shock and aggressive resuscitation. Initiating MTPs based on clinical indicators of massive hemorrhage, such as hemodynamic instability despite initial fluid resuscitation and evidence of coagulopathy, is a proactive measure that can prevent irreversible shock and death. This approach is supported by evidence demonstrating improved survival rates in trauma patients receiving balanced component therapy early. Ethically, it prioritizes the patient's life and well-being, fulfilling the duty of care. Regulatory frameworks for trauma care, including those implicitly guiding ATLS, mandate timely and appropriate interventions for life-threatening conditions. An incorrect approach of delaying MTP initiation until laboratory confirmation of coagulopathy is professionally unacceptable. This delay can be fatal, as coagulopathy can develop rapidly in massive hemorrhage and laboratory results are not instantaneous. This failure to act decisively in a time-sensitive situation violates the ethical principle of beneficence and potentially non-maleficence by allowing preventable harm. It also contravenes the spirit of ATLS, which stresses the importance of clinical assessment over solely relying on delayed diagnostics in emergent situations. Another incorrect approach of initiating MTPs based solely on the volume of crystalloid infused, without considering the patient's hemodynamic status or evidence of ongoing bleeding, is also professionally unsound. Large volumes of crystalloid can dilute clotting factors. The decision to activate a resource-intensive MTP should be guided by the clinical picture of shock and coagulopathy, not just a number. This could lead to unnecessary use of blood products, exposing the patient to transfusion-related risks and depleting scarce resources. This approach lacks the nuanced clinical judgment required for optimal patient management and resource allocation. Finally, an incorrect approach of withholding MTPs due to concerns about the cost of blood products, without a clear clinical contraindication, is ethically and professionally indefensible. The primary responsibility of a healthcare provider is to save lives and mitigate harm. Financial considerations, while important in healthcare systems, should not supersede the immediate need for life-saving treatment in a patient experiencing massive hemorrhage. This approach prioritizes economic factors over patient survival, a clear ethical failure. The professional decision-making process for similar situations should involve a rapid, systematic assessment of the patient's airway, breathing, circulation, and disability. In the context of suspected massive hemorrhage, the clinician must continuously evaluate hemodynamic stability, response to initial resuscitation, and signs of coagulopathy, e.g., prolonged bleeding from insertion sites, abdominal distension. If the patient is hemodynamically unstable despite adequate fluid resuscitation, or shows signs of coagulopathy, the threshold for initiating MTP should be low. This decision should be made collaboratively with the trauma team and blood bank, adhering to established institutional protocols for MTP activation. Question 11. Benchmark analysis indicates that a 45-year-old male presents to the emergency department following a motor vehicle collision. He is hypotensive, BP 80/50 mmHg, tachycardic, HR 130 bpm, hyposic, SpO2 85% on room air, and has diminished breath sounds on the left side with a tracheal deviation to the right. Which of the following immediate management strategies is most consistent with advanced trauma life support ATLS principles for this patient? Option A. Administer a rapid bolus of intravenous crystalloids to improve blood pressure. Option B. Proceed with endotracheal intubation to secure the airway and improve oxygenation. Option C. Immediate needle decompression of the left hemithorax followed by a chest tube insertion. Option D. Obtain a portable chest X-ray to confirm the diagnosis before initiating any invasive procedures. The correct answer is C. Immediate needle decompression of the left hemithorax followed by a chest tube insertion. Explanation. This scenario is professionally challenging due to the rapid deterioration of a patient with suspected tension pneumothorax, demanding immediate and decisive action based on clinical signs rather than solely on imaging, which can be time-consuming. The ATLS framework prioritizes life-saving interventions in critical situations. The correct approach represents best professional practice because it aligns directly with ATLS guidelines for managing tension pneumothorax. ATLS mandates immediate needle decompression or finger thoracostomy for patients exhibiting signs of tension pneumothorax, hypotension, hypoxia, tracheal deviation, absent breath sounds, even in the absence of definitive radiographic confirmation. This rapid intervention is crucial to relieve the mediastinal shift and restore hemodynamic stability, directly addressing the life-threatening physiology. Ethically, this approach upholds the principle of beneficence by acting swiftly to prevent further harm and preserve life. Regulatory frameworks, such as those guiding emergency medical services and hospital protocols, are built upon these life-saving principles established by ATLS. An incorrect approach involving delaying intervention until chest X-ray confirmation is professionally unacceptable. This delay directly violates ATLS principles, which emphasize that clinical diagnosis is sufficient for emergent decompression. Radiographic confirmation introduces a critical delay that can lead to irreversible shock and death, failing the ethical principle of non-maleficence by allowing preventable harm. Furthermore, it demonstrates a failure to adhere to established best practice guidelines, potentially leading to regulatory scrutiny and professional liability. Another incorrect approach, such as administering intravenous fluids without addressing the underlying mechanical obstruction, is also professionally unacceptable. A fluid resuscitation is important in shock management. It is insufficient and potentially detrimental when a tension pneumothorax is present. The primary issue is impaired venous return due to mediastinal shift, which fluids alone cannot correct. This approach fails to address the root cause of the patient's instability and represents a significant lapse in clinical judgment, contravening ATLS protocols that prioritize immediate decompression. A further incorrect approach, such as attempting endotracheal intubation without first decompressing the chest, is also professionally unacceptable. While intubation may be necessary for airway management, performing it in a patient with a tension pneumothorax can worsen the hemodynamic compromise by increasing intrathoracic pressure. ATLS emphasizes addressing the most immediate life threats first. Failure to decompress the chest prior to or concurrently with other interventions demonstrates a misunderstanding of the pathophysiology and a failure to apply the ATLS algorithm correctly, leading to potential patient harm and professional failure. The professional reasoning process for similar situations should involve a rapid assessment of the airway, breathing, circulation, disability, exposure. In a patient with suspected tension pneumothorax, the B breathing and C circulation are critically compromised. The presence of hypotension, hypoxia, unilateral absent breath sounds, and potentially tracheal deviation should trigger immediate consideration of tension pneumothorax. The ATLS algorithm dictates that if clinical signs are present, intervention should proceed without delay for imaging. The decision-making framework prioritizes life-saving interventions based on clinical suspicion when time is of the essence, adhering to established protocols to ensure the best possible patient outcome. Question 12. The performance metrics show a pattern where initial resuscitation of hypotensive trauma patients predominantly utilizes large volumes of isotonic crystalloids, with a significant proportion requiring subsequent fluid boluses and ongoing monitoring for signs of fluid overload. Considering the principles of advanced trauma life support ATLS and the available evidence on fluid resuscitation, which of the following represents the most appropriate clinical decision-making framework for managing hemorrhagic shock in this context? Option A. Initiate resuscitation with isotonic crystalloids, and if the patient remains hypotensive after initial boluses, judiciously consider the use of colloids such as albumin to improve oncotic pressure and maintain intravascular volume, while simultaneously addressing the source of hemorrhage. Option B. Continue administering large volumes of isotonic crystalloids until hemodynamic stability is achieved, as they are readily available and cost-effective, and reassess for colloid use only if refractory shock persists after extensive crystalloid administration. Option C. Prioritize the administration of colloid solutions, such as hydroxyethyl starches, from the outset of resuscitation to maximize intravascular volume expansion and minimize the need for large fluid volumes. Option D. Immediately switch to administering hypertonic saline solutions, as they are known to rapidly expand intravascular volume and improve tissue perfusion in hypotensive trauma patients. The correct answer is B. Continue administering large volumes of isotonic crystalloids until hemodynamic stability is achieved, as they are readily available and cost-effective, and reassess for colloid use only if refractory shock persists after extensive crystalloid administration. Explanation. The performance metrics show a trend of increased fluid administration in trauma patients presenting with hemorrhagic shock. This scenario is professionally challenging because the choice between crystalloids and colloids for resuscitation is a critical decision with significant implications for patient outcomes, resource utilization, and adherence to evidence-based guidelines. Clinicians must balance the immediate need for volume expansion with the potential for adverse effects and the cost-effectiveness of different fluid types. The correct approach involves a nuanced understanding of the current ATLS guidelines and supporting evidence regarding fluid resuscitation in trauma. ATLS emphasizes prompt restoration of circulating volume to maintain oxygen delivery. While crystalloids are readily available and cost-effective, their rapid extravasation can necessitate large volumes, potentially leading to fluid overload and edema. Colloids, such as albumin or starches, can theoretically maintain intravascular volume for longer periods due to their oncotic properties. However, concerns regarding adverse effects of some colloids, e.g., renal dysfunction with certain starches, and their higher cost necessitate careful consideration. The ATLS framework, while not mandating one over the other universally, guides clinicians to use the most appropriate fluid based on patient presentation, response to initial resuscitation, and availability, always prioritizing the restoration of perfusion. The decision should be guided by clinical assessment of response to therapy, rather than a rigid adherence to a single fluid type. An incorrect approach would be to exclusively rely on crystalloids without reassessing the patient's response and considering the potential benefits of colloids in specific refractory shock states, or conversely, to indiscriminately use colloids without considering their potential risks and cost. Another incorrect approach would be to delay definitive hemorrhage control in favor of aggressive fluid resuscitation, which is contrary to the ATLS principle of identifying and managing the cause of shock. Ethically, failing to consider the most effective and safest resuscitation strategy for the individual patient, or choosing a fluid based solely on cost without considering efficacy, would be a failure of professional duty. Regulatory frameworks, including those underpinning ATLS, mandate evidence-based practice and patient-centered care. The professional decision-making process should involve a rapid assessment of the patient's hemodynamic status, identification of the likely cause of shock, e.g., hemorrhagic, and initiation of resuscitation with readily available isotonic crystalloids. This should be followed by continuous reassessment of the patient's response to therapy. If the patient remains hypotensive despite adequate crystalloid resuscitation, or if there are specific indications for colloid use, e.g., severe hypoalbuminemia, refractory shock, the clinician should consider the judicious use of colloids, weighing their potential benefits against risks and costs, while simultaneously pursuing definitive hemorrhage control. This iterative process ensures that resuscitation strategies are tailored to the evolving needs of the trauma patient. Question 13. Consider a scenario where a 45-year-old male is brought to the trauma bay following a high-speed motor vehicle collision. On primary survey, he is hypotensive, BP 80/50 mmHg, tachycardic, HR 130 bpm, with diminished breath sounds on the left and tracheal deviation to the right. A rapid ultrasound for trauma, FAST, exam reveals a large left-sided hemothorax. Given these findings and the ATLS guidelines, what is the most appropriate next step in management? Option A. Aggressive fluid resuscitation and repeat FAST exam in 15 minutes. Option B. Computed tomography CT scan of the chest to delineate the injury. Option C. Immediate left-sided thoracotomy. Option D. Insertion of a large bore chest tube on the left side. The correct answer is C. Immediate left-sided thoracotomy. Explanation. This scenario presents a professionally challenging situation due to the critical nature of a tension pneumothorax and the immediate need for life-saving intervention. The ATLS framework emphasizes rapid assessment and management of life-threatening conditions. The challenge lies in accurately diagnosing the condition and initiating the most appropriate and timely intervention, balancing the urgency with the need for a definitive surgical solution when indicated. The correct approach, performing a thoracotomy, represents best professional practice because it directly addresses the underlying pathology of a massive hemothorax and potential ongoing intrathoracic bleeding or cardiac tamponade, which are contraindications for less invasive procedures like chest tube insertion alone. ATLS guidelines prioritize definitive management for severe thoracic trauma. A thoracotomy allows for direct visualization, control of hemorrhage, repair of damaged structures, and evacuation of the hemothorax, which is crucial for hemodynamic stability and preventing complications like re-expansion pulmonary edema or retained hemothorax. This aligns with the ATLS principle of addressing the C, circulation, and D, disability/exposure, components of the primary survey when severe thoracic injuries compromise circulation. An incorrect approach, such as delaying definitive surgical intervention to await further imaging or attempting to manage solely with chest tube insertion in the face of massive hemothorax, would represent a failure to adhere to ATLS principles of rapid intervention for life-threatening conditions. This delay could lead to irreversible shock, organ damage, and death. Relying solely on a chest tube for massive hemothorax without addressing the source of bleeding or potential cardiac tamponade is inadequate and potentially harmful, violating the principle of providing definitive care when indicated. Another incorrect approach, such as proceeding directly to a thoracotomy without a clear indication or adequate resuscitation, would be a failure of proper assessment and resource utilization, potentially leading to unnecessary surgical morbidity. Professional decision-making in such situations requires a systematic approach, rapid primary and secondary surveys according to ATLS protocols, prompt recognition of signs of severe thoracic injury, e.g., hypotension, absent breath sounds, tracheal deviation, distended neck veins, and immediate consideration of interventions based on the severity of findings. When massive hemothorax or signs of cardiac tamponade are present, the decision-making process should quickly escalate to considering a thoracotomy as the definitive management strategy, balancing the risks of surgery against the immediate threat to life. Question 14. The investigation demonstrates a patient presenting with severe facial trauma and suspected cervical spine injury, exhibiting paradoxical chest movement and audible stridor, with initial attempts at bag valve mask ventilation proving ineffective in achieving adequate chest rise. Option A. Immediate cricothyroidotomy without first attempting a supraglottic airway. Option B. Insertion of a supraglottic airway device to secure the airway and facilitate ventilation. Option C. Reliance solely on bag valve mask ventilation with high-flow oxygen, accepting suboptimal ventilation. Option D. Continued prolonged attempts at orotracheal intubation without considering alternative airway adjuncts. The correct answer is B. Insertion of a supraglottic airway device to secure the airway and facilitate ventilation. Explanation. This scenario presents a common challenge in emergency medicine: the need for rapid airway management in a patient with compromised ventilation, where definitive endotracheal intubation may be difficult or delayed. The ATLS framework emphasizes the importance of securing an airway quickly to prevent secondary brain injury and organ damage. The professional challenge lies in selecting the most appropriate alternative airway device when standard intubation is not immediately feasible, balancing speed of insertion with effectiveness and potential complications. Careful judgment is required to assess the patient's anatomy, the urgency of the situation, and the available resources. The correct approach in this context represents best professional practice by adhering to the ATLS principles of airway management. ATLS guidelines prioritize rapid oxygenation and ventilation. When supraglottic airways, SGA, are indicated due to anticipated or encountered difficulty with endotracheal intubation, their use is supported by evidence demonstrating faster insertion times and comparable or superior ventilation outcomes in many scenarios compared to prolonged attempts at intubation. This approach aligns with the ethical imperative to provide timely and effective care, minimizing patient harm. An incorrect approach would involve delaying definitive airway management or choosing an inappropriate alternative. For instance, relying solely on bag valve mask ventilation without a plan for definitive airway control in a patient with persistent hypoxemia or inadequate ventilation would be a failure to adhere to ATLS principles. Another incorrect approach would be to attempt multiple, prolonged endotracheal intubation attempts without considering or utilizing an SGA when indicated, potentially leading to esophageal trauma, hypoxia, and increased patient distress. Ethically, this constitutes a failure to act with due diligence and to employ evidence-based practices to optimize patient outcomes. The professional decision-making process should involve a rapid assessment of the patient's airway, breathing, and circulation, ABC. If endotracheal intubation is anticipated to be difficult or is unsuccessful, the ATLS algorithm directs consideration of alternative airway devices, including SGAs. The decision to use an SGA should be based on the provider's skill set, the patient's specific anatomy, and the urgency of the situation. The goal is to achieve adequate oxygenation and ventilation as quickly as possible, with a clear plan for conversion to endotracheal intubation if necessary or appropriate. Question 15. Upon reviewing a trauma patient presenting with severe dyspnea, unilateral absent breath sounds, and hypotension, which of the following diagnostic and management strategies best aligns with the Advanced Trauma Life Support ATLS guidelines for immediate life-threatening chest injuries? Option A. Administer analgesia and monitor the patient's respiratory status closely, anticipating that a simple pneumothorax will resolve spontaneously. Option B. Perform immediate needle decompression in the second intercostal space, midclavicular line, followed by chest tube insertion, given the high suspicion for tension pneumothorax. Option C. Administer oxygen, initiate intravenous fluid resuscitation, and obtain a portable chest X-ray to confirm the diagnosis before proceeding with any invasive procedures. Option D. Focus on controlling external bleeding and administering blood products, assuming the hypotension is primarily due to hemorrhagic shock from other injuries, and deferring chest interventions until the patient is stabilized. The correct answer is C. Administer oxygen, initiate intravenous fluid resuscitation, and obtain a portable chest X-ray to confirm the diagnosis before proceeding with any invasive procedures. Explanation. This scenario is professionally challenging due to the rapid deterioration of a patient with suspected chest trauma, requiring immediate and accurate differentiation of potentially life-threatening injuries. ATLS framework emphasizes a systematic approach to trauma management, prioritizing interventions based on physiological compromise. Misinterpreting the signs and symptoms of different chest injuries can lead to delayed or inappropriate treatment, significantly impacting patient outcomes. The correct approach represents best professional practice by adhering to the ATLS principles of rapid assessment and management of airway, breathing, and circulation. Specifically, recognizing the signs of tension pneumothorax, e.g., tracheal deviation, hypotension, absent breath sounds on one side, and initiating immediate needle decompression is a critical intervention mandated by ATLS guidelines for immediate life threats. This aligns with the ethical obligation to provide timely and effective care in emergent situations. An incorrect approach of delaying definitive management while awaiting imaging studies for a patient with signs of tension pneumothorax is a significant regulatory and ethical failure. ATLS explicitly states that clinical diagnosis of tension pneumothorax is sufficient for immediate intervention, and delaying decompression based on the need for imaging would violate the principle of acting in the patient's best interest and could be considered a breach of the standard of care. Another incorrect approach of treating all chest trauma as simple contusions without considering the possibility of more severe injuries like hemothorax or pneumothorax, and thus not performing a chest tube insertion when indicated by significant hemoptysis or persistent hypotension with signs of bleeding, also represents a failure to follow ATLS protocols and a potential deviation from the standard of care. Professional decision-making in such situations requires a thorough understanding of the ATLS algorithm. This involves rapid primary survey to identify immediate life threats, followed by secondary survey and appropriate investigations. For chest injuries, this means recognizing the classic presentations of pneumothorax, tension pneumothorax, hemothorax, and flail chest, and understanding the immediate interventions required for each. The decision-making process should prioritize intervention that address physiological derangements over diagnostic confirmation when immediate life-saving measures are indicated. Question 16. The assessment process reveals a multi-vehicle collision with numerous casualties presenting to the scene. Among the injured are individuals with obvious severe bleeding, those who are conscious but disoriented, and others who are unresponsive. In this mass casualty incident, which of the following actions best reflects the application of ATLS triage principles for immediate resource allocation? Option A. Focus initial efforts on the patient who is most vocal and demanding of attention to de-escalate potential panic. Option B. Rapidly categorize patients into immediate, delayed, minimal, and expectant groups based on their physiological status and the likelihood of survival with available resources. Option C. Dedicate significant time to obtaining detailed medical histories and performing comprehensive physical examinations on each patient before assigning any priority. Option D. Prioritize the patient with the most visible and severe external injuries, ensuring they receive immediate attention and transport. The correct answer is B. Rapidly categorize patients into immediate, delayed, minimal, and expectant groups based on their physiological status and the likelihood of survival with available resources. Explanation. The assessment process reveals a mass casualty incident with multiple patients presenting with varying degrees of injury. The professional challenge lies in the rapid and accurate prioritization of care under extreme pressure, where limited resources must be allocated to those most likely to benefit from immediate intervention. This scenario demands adherence to established triage principles to ensure the greatest good for the greatest number, a core ethical and regulatory tenet of emergency medical services. The correct approach, prioritizing patients based on the likelihood of survival and the severity of their injuries using a recognized triage system, such as START or SALT, as per ATLS guidelines, represents best professional practice. This systematic methodology ensures that resources are directed towards those with critical, yet potentially reversible, conditions. It aligns with ATLS principles which emphasize a structured approach to trauma management, including initial assessment and prioritization. The regulatory framework for emergency medical services mandates the use of such evidence-based triage systems to ensure equitable and effective patient care in mass casualty events. An incorrect approach that involves treating the first patient encountered, regardless of their condition, fails to acknowledge the principles of mass casualty management. This is a regulatory failure as it deviates from mandated protocols designed to optimize resource allocation. Ethically, it prioritizes one individual over potentially many others, who may have a higher chance of survival with timely intervention. Another incorrect approach, focusing solely on the most severely injured patient without considering their prognosis or the resources required, can lead to the depletion of critical resources on a patient with a low likelihood of survival, thereby compromising care for others. This is a failure to adhere to the core principle of maximizing survival outcomes in a mass casualty event, a key component of ATLS and emergency medical regulations. Furthermore, an approach that delays triage to gather extensive patient histories or perform detailed examinations on every individual is inefficient and contrary to the rapid assessment required in a mass casualty incident. This is a regulatory and ethical failure as it wastes valuable time and resources, potentially leading to preventable deaths due to delayed treatment for other patients. The professional decision-making process in such situations should involve immediate scene assessment, rapid patient categorization using a standardized triage tool, and continuous reassessment. Professionals must remain objective, applying established protocols consistently, and communicating effectively with their team to ensure efficient resource deployment and optimal patient outcomes. This systematic approach, grounded in ATLS principles, is crucial for navigating the complexities of mass casualty incidents. Question 17. Examination of the data shows a hypotensive, tachypneic trauma patient with decreased breath sounds on the left. Initial airway assessment reveals no obvious obstruction, but the patient is unable to protect their airway. What is the most appropriate initial ventilation strategy following definitive airway management? Option A. Mechanical ventilation with a tidal volume of 6-8 ml/kg ideal body weight, a respiratory rate of 10-12 breaths per minute, an appropriate PEEP to maintain adequate oxygenation. Option B. Mechanical ventilation with a tidal volume of 10-12 ml/kg ideal body weight and a respiratory rate of 20-24 breaths per minute to ensure rapid oxygen delivery. Option C. Prolonged reliance on bag valve mask ventilation until the patient's hemodynamic status improves significantly. Option D. Immediate initiation of high-frequency jet ventilation to optimize gas exchange in a potentially compromised chest. The correct answer is A. Mechanical ventilation with a tidal volume of 6-8 ml/kg ideal body weight, a respiratory rate of 10-12 breaths per minute, an appropriate PEEP to maintain adequate oxygenation. Explanation. This scenario presents a professionally challenging situation due to the immediate need to establish adequate ventilation in a critically injured patient with potential airway compromise and respiratory distress. The ATLS framework emphasizes rapid assessment and intervention to prevent secondary brain injury and organ hypoperfusion, making ventilation a cornerstone of initial management. Careful judgment is required to select the most appropriate ventilation strategy that supports oxygenation and ventilation without causing barotrauma or volatrauma, considering the patient's specific injuries and physiological status. The correct approach represents best professional practice by prioritizing a controlled ventilation strategy that allows for precise management of tidal volume and respiratory rate, aligning with ATLS guidelines for managing airway and breathing. This approach ensures adequate gas exchange while minimizing the risk of ventilator-induced lung injury, which is a critical consideration in trauma patients who may have underlying lung contusions or edema. Adherence to ATLS principles for airway management and ventilation is ethically mandated to provide the highest standard of care and prevent iatrogenic harm. An incorrect approach that involves immediate high-frequency jet ventilation without a clear indication of failure of conventional ventilation would be a regulatory and ethical failure. ATLS protocols advocate for a stepwise approach, and resorting to advanced techniques prematurely can lead to complications and may not address the underlying cause of respiratory compromise. Another incorrect approach, such as relying solely on bag valve mask ventilation for an extended period without securing the airway, represents a failure to adhere to ATLS standards for definitive airway management, increasing the risk of aspiration and inadequate ventilation, which is a breach of professional duty. Finally, initiating positive end expiratory pressure (PEEP) at excessively high levels without careful titration can lead to hemodynamic instability and barotrauma, violating the principle of do no harm. Professional reasoning in such situations should follow the ATLS algorithm, assess the airway, breathing, and circulation. If the patient cannot maintain a patent airway or adequate ventilation, secure the airway. Once secured, initiate mechanical ventilation, titrating settings to achieve adequate oxygenation and ventilation while minimizing ventilator-induced lung injury. Continuous reassessment of the patient's response to ventilation is paramount. Question 18. Performance analysis shows that initial trauma assessment accuracy is significantly influenced by the clinician's ability to correctly identify the primary mechanism of injury. A patient presents to the emergency department following a motor vehicle collision. The patient was a driver who was wearing a seatbelt, and the vehicle sustained significant frontal impact. The patient is conscious but appears disoriented. Which of the following initial assessments is most consistent with the expected injuries from this mechanism? Option A. Focusing on potential deceleration injuries, including thoracic and abdominal organ damage and skeletal fractures, while considering the forces applied to the body. Option B. Immediately initiating a secondary survey without a thorough primary survey, as the mechanism is clearly blunt trauma. Option C. Prioritizing assessment for direct organ laceration from a penetrating object and immediate exploration of all abdominal wounds. Option D, assuming the seatbelt protected the patient from significant internal injury and focusing solely on external abrasions and contusions. The correct answer is C, prioritizing assessment for direct organ laceration from a penetrating object and immediate exploration of all abdominal wounds. Explanation: this scenario is professionally challenging because accurately differentiating between blunt and penetrating trauma mechanisms is fundamental to initiating the correct ATLS primary and secondary surveys. Misinterpreting the mechanism can lead to overlooking critical injuries or pursuing diagnostic pathways that are not immediately indicated, delaying definitive care. The ATLS framework prioritizes rapid assessment and intervention based on the mechanism of injury to identify and manage life-threatening conditions. The correct approach represents best professional practice because it aligns directly with the ATLS principles of rapid assessment and management. By recognizing the distinct characteristics of blunt trauma, e.g., deceleration, compression, shearing forces, and penetrating trauma, e.g., direct tissue damage, cavitation, the clinician can anticipate specific injury patterns. For blunt trauma, this might involve a heightened suspicion for internal organ damage, skeletal fractures, and head injuries due to widespread forces. For penetrating trauma, the focus shifts to the trajectory of the object, potential organ damage along that path, and the risk of hemorrhage. This systematic approach ensures that the patient receives the most appropriate initial management and diagnostic workup according to established ATLS guidelines, which are designed to optimize outcomes in trauma patients. An incorrect approach that fails to distinguish between blunt and penetrating mechanisms is professionally unacceptable. For instance, treating a patient with a suspected penetrating injury as if it were solely blunt trauma might lead to a delayed exploration for internal bleeding or missed organ perforation. This failure to adhere to the ATLS protocol, which mandates a specific initial assessment based on mechanism, constitutes a deviation from best practice and could result in adverse patient outcomes. Similarly, overemphasizing superficial findings in a penetrating injury while neglecting the potential for deeper damage due to the object's path would be a critical error. These failures represent a breakdown in the systematic, evidence-based approach that ATLS promotes, potentially violating ethical obligations to provide competent care. Professional reasoning in such situations involves a rapid, yet thorough, initial assessment. The clinician must actively consider the forces involved in the injury. For blunt trauma, questions should focus on the type of impact, speed of the vehicle if applicable, height of fall, and whether the patient was restrained. For penetrating trauma, the focus is on the type of object, number of wounds, and the estimated path. This information directly informs the subsequent steps of the ATLS survey, guiding the clinician's index of suspicion for specific injuries and the urgency of diagnostic interventions. Question 19. Governance review demonstrates a recent incident where a patient presenting with a large, bleeding scalp laceration was immediately taken for wound exploration and suturing, delaying a full primary survey. The patient subsequently developed respiratory distress due to an undiagnosed tension pneumothorax. Considering the Advanced Trauma Life Support ATLS certification framework, which of the following initial management strategies would be considered the most appropriate and compliant? Option A. Immediately initiate a primary survey focusing on airway, breathing, circulation, disability, and exposure, ATLS, to identify and manage any immediate life threats before addressing the scalp laceration. Option B. Administer intravenous fluids and pain medication for the scalp laceration, while awaiting further diagnostic imaging to rule out associated injuries. Option C. Proceed directly to a secondary survey to gather a detailed history and perform a head-to-toe examination, assuming the patient is stable enough for this detailed assessment. Option D. Prioritize definitive management of the most visible and alarming injury, the scalp laceration, to control bleeding and provide immediate cosmetic improvement. Correct answer is A. Immediately initiate a primary survey focusing on airway, breathing, circulation, disability, and exposure, ATLS, to identify and manage any immediate life threats before addressing the scalp laceration. Explanation: this scenario presents a common challenge in trauma care, managing a patient with multiple, potentially life-threatening injuries where the initial presentation may obscure the severity of certain conditions. The professional challenge lies in systematically assessing and prioritizing interventions based on established protocols to ensure the most critical issues are addressed first, preventing deterioration. The ATLS framework is designed to address this by providing a structured, step-by-step approach that minimizes the risk of overlooking critical injuries. The correct approach represents best professional practice because it adheres strictly to the ATLS principles of primary and secondary surveys. This systematic methodology ensures a comprehensive evaluation, prioritizing immediate life threats, airway, breathing, circulation, disability, exposure of death, before delving into less urgent details. This aligns with the ethical obligation to provide timely and effective care, minimizing harm and maximizing the chance of survival. The ATLS guidelines themselves are the regulatory framework in this context, dictating the standard of care for initial trauma management. An incorrect approach that deviates from the ATLS sequence, such as focusing on a seemingly obvious but less immediately life-threatening injury before securing the airway or assessing circulation, represents a significant regulatory and ethical failure. This deviation can lead to delayed management of critical issues, potentially resulting in irreversible damage or death. It violates the core principle of ATLS, which is to identify and manage life-threatening conditions first. Another incorrect approach might involve prematurely concluding the assessment without a thorough secondary survey, potentially missing subtle but critical injuries that could manifest later. This failure to be exhaustive, as mandated by the ATLS secondary survey, is a breach of professional duty. The professional decision-making process in such situations should be guided by the ATLS algorithm. This involves a rapid, systematic primary survey to identify and manage immediate life threats. If the patient is stabilized, a secondary survey is then performed to gather more detailed information and identify any remaining injuries. Throughout this process, continuous reassessment of the patient's death status is paramount. Professionals must constantly ask, what is the most immediate threat to this patient's life? And act accordingly, always within the established ATLS protocol. Question 20. Analysis of a 45-year-old male involved in a high-speed motor vehicle collision. He presents to the trauma bay with significant facial lacerations, a suspected mid-face fracture, and is obtunded with a Glasgow Coma Scale score of 7. His respiratory rate is 8 breaths per minute, shallow, with audible gurgling. Initial oxygen saturation is 88% on room air. Given these findings, which of the following represents the most appropriate initial definitive airway management strategy according to ATLS principles? Option A. Attempt blind nasal intubation given the facial trauma. Option B. Continue bag valve mask BVM, ventilation, and reassess in 5 minutes. Option C. Perform a needle cricothyroidotomy immediately due to the patient's obtunded state and low GCS. Option D. Attempt rapid sequence intubation, RSI, with appropriate pharmacologic agents and suctioning. The correct answer is D. Attempt rapid sequence intubation, RSI, with appropriate pharmacologic agents and suctioning. Explanation. This scenario presents a common yet critical challenge in trauma care. A patient with a compromised airway requiring immediate intervention. The professional challenge lies in rapidly assessing the airway, identifying the most appropriate management strategy based on the patient's presentation and the available resources, and executing that strategy effectively while anticipating potential complications. The ATLS framework emphasizes a systematic approach to airway management, prioritizing interventions that secure the airway while minimizing further harm. The correct approach, involving rapid sequence intubation, RSI, with appropriate pharmacologic agents and adjuncts, represents best professional practice as dictated by ATLS guidelines. ATLS mandates a definitive airway be secured promptly in patients with compromised airways. RSI is the preferred method for endotracheal intubation in most trauma patients, as it allows for rapid induction of anesthesia and paralysis, facilitating intubation with a lower risk of aspiration and hemodynamic compromise compared to awake intubation or other less definitive methods. The choice of specific agents would be guided by patient factors and local protocols, but the principle of rapid, controlled intubation is paramount. This aligns with the ethical principle of beneficence, acting in the patient's best interest to ensure adequate oxygenation and ventilation. An incorrect approach, such as attempting a blind nasal intubation in a patient with suspected facial fractures and significant bleeding, poses significant regulatory and ethical failures. Blind nasal intubation carries a high risk of complications in this context, including further injury to the nasal passages, skull base penetration, and failure to secure the airway, leading to hypoxia and potential brain injury. This violates the principle of non-maleficence, do no harm, and falls short of the standard of care expected in trauma management. Another incorrect approach, delaying definitive airway management in favor of less effective measures like bag valve mask, BVM. Ventilation alone would be a critical failure. While BVM can provide temporary ventilation, it is not a definitive airway and is often insufficient in patients with significant airway obstruction or hypoventilation. Prolonged reliance on BVM in a deteriorating patient constitutes a failure to provide timely and appropriate care, potentially leading to irreversible organ damage or death, and is a clear deviation from ATLS principles. A third incorrect approach, proceeding directly to a surgical airway, e.g., cricothyroidotomy, without a thorough attempt at less invasive methods like RSI, would also be professionally challenging. While surgical airways are life-saving in specific circumstances, e.g., failed intubation, they are associated with higher complication rates and should generally be reserved for situations where endotracheal intubation is not feasible or has failed. Prematurely resorting to a surgical airway without exhausting less invasive options could be considered an unnecessary intervention, potentially causing harm. Professional decision-making in such situations requires a rapid assessment of the A, B, C, D, E of ATLS. The clinician must quickly determine if the airway is patent, if it can be protected, and if ventilation is adequate. Factors such as facial trauma, suspected cervical spine injury, level of consciousness, and the presence of secretions or blood all influence the choice of airway management. The decision-making process involves weighing the risks and benefits of each intervention, considering the patient's physiological status, and anticipating potential complications. A systematic, evidence-based approach, as outlined by ATLS, is crucial for optimal patient outcomes.